So sometimes, you know, you've seen this, I have people I've seen 100 times, okay? No exaggeration. But they got other medical issues and problems, so you always want to just sick, you know, these crazy people get sick, these drug seekers get sick, so don't blow people off, okay? It's really easy to be judgmental, it's really easy to make your diagnosis based off their 99 other visits, okay? But you always got to have an open mind and listen to what these people are saying, okay? Use your gut. I had a rollover meth van. Girl was ejected, she was positive for everything. The night team, trauma team saw her, and so kind of our rule was at that time, they had a radiology resident kind of reading studies at night. The official radiologist got the official read the following day, and to get the official read. So obviously, people intoxicated stay in spine precautions. So she had a seat collar on, and she's laying flat. She had some TNL spine precautions. All the X-rays are read normal by the radiologist. Okay, so I go in and see her, and pain out of proportion to exam. Her neck pain, just crazy. A little swelling maybe, a little bit of visual examination. But her x-rays are read as normal. We CT'd her, she had a purse facet at C4 and C5. She had transverse foramen fractures, and she had a vertebral artery. Okay, dissection. And even retrospectively going back and looking at the plain films and lateral C-spine x-rays, you didn't see anything. Okay, pain out of proportion to exam. Okay, you're not going to sleep. It's crazy all the sleepless nights you get, like, oh, God, I wish I'd CT'd that late. Oh, I wish I'd have done that. You get to have these sleepless nights. You have sometimes if you think about these patients, sometimes you take these home and you're like, oh gosh, we're not that late, I'm worried about her. You know? So, you know, if you're ever concerned or paying a portion exam, do the extra diagnostic studies that you need. Okay? Bounce it off with someone else. So compartment syndromes. Y'all know about compartment syndromes? Look at compartment syndromes? Okay. Types, pathophysiology, etiology, clinical evaluation, diagnosis, management, complications. So definition of compartment syndrome is an elevation in the interstitial pressure in a closed compartment that results in microvascular compromise. If it's untreated, it will cause neurovascular damage. Okay? You would not believe how many times I get patients referred to me from outlying facilities or physician's office. They think they have compartment syndrome. And it's one of those things that, again, we're okay with over triage, not under triage. Okay? So, you know, 90% of the time, these are nothing, okay, other than a little hematoma, a little swelling. But you know, it's because a lot of times these people don't see those many things. They don't see it very often. They're not comfortable with it. See, again, you always want to, yes, a pain in the butt. Some seeing patients that don't need to be there. So on the other end, you know, if someone's not comfortable with it, you know, they send it to you because they're not sure and they want to be sure. So don't give people a hard time about sending patients that sometimes don't necessarily need to be there. Their safety and best interest is in their hand. Okay. Compartment syndromes, relatively non-compliant fascial or osseous structures most commonly involved, especially in the anterior compartment of the leg or the lower compartment of the forearm. The leg is the most common place you see compartment syndrome. These people that have these multiple fractures from car accidents or falls, okay, crush injuries. Typically, compartment syndrome is classified in chronic or acute. Okay. Signs of acute compartment syndrome can develop anywhere skeletal muscle surrounded by substantial fascia, maker in the foot, the leg. The lumbar and the back stuff don't happen often, but hand, forearm, arm, and shoulder. So compartments, there's 9 in the foot, 4 in the leg, 4 in the hand, 3 in the thigh, in the forearm there's 4. I always give this anatomy thing in there for Dr. McNeil, the mobile lot of Henry. Anybody know what the mobile lot of Henry is? Of Dr. McNeil? Which your extensor carpi radialis, or extensor carpi longus and brevis, and the brachioradialis. Pathophysiology. Compartment syndrome develops after prolonged elevated intercompartmental pressure, which results from either externally applied or internal expanding pressure. Okay? What some are external pressures? Okay, whether it's a crush injury, a splint, okay, gauze, a brace, okay. Internal pressures would be bleeding, swelling, okay. So increased tissue pressure will decrease capillary blood flow, leading to tissue necrosis caused by oxygen deprivation. Okay? Local blood flow is your arterial pressure minus your venous pressure divided by your resistance. The elevated intercompartmental pressure increases local venous pressure, leading to narrowed arteriovenous perfusion, gradient compartment tamponade, resulting if uncontrolled from nerve and muscle ischemia. Okay? What causes it? External restriction we talked about, cast, tight dressing, splints. Lots of times you have these people who are found down, okay? They've been laying on their arm for 8 hours, okay? So time's important, okay? Burn scar, okay? Y'all know what one of the, one of the things you talk about documentation, okay, with burns, what's the one thing you want to document on every patient about a burn? Surface area, okay? Circumferential, okay? Every burn that you document in your test, you want to burn it is or is not circumferential. Circumferential burns increase your risk of getting compartment syndrome, okay? Because the burn is 360 degrees, that swelling, that tissue swells down and it's tight. So anytime you document someone has a burn, okay, pertinent, positive, negative. Is circumferential, is not circumferential, okay? Internal stuff, talk about fractures, okay, bleeding. Hemorrhage due to vascular injuries, okay? People, one of the things you always have to ask for every patient, okay? And sometimes you have to ask them in several different ways, okay? An old person that falls and hits their head, what do you want to know? What medicines they're on? Okay, aspirin, Coumadin. But you also got to ask them about some of the blood thinners, okay? The 10A inhibitors, okay? You're on Xarelto, are you on Eliquis, okay? So, knowing what they're on, kind of based off of when sometimes people aren't cognizant, are you on a blood thinner? Sometimes they may say no. Then sometimes ask them, do you take aspirin? Do you take Xarelto? Do you take Coumadin? So sometimes you have to ask these people, okay? I had a guy that came in, simple thing. He bought a new house. He walked in, doing the walkthrough through his house, everything's empty, he had his head on a cabinet. Had a simple laceration. He comes in with his brother, comes in with his nephew, he's alert, he's awake, he's just said 15. He denied he taking any blood thinners on an exam, he's an old guy. Old people scan their heads and hit their head. Okay? So he gets under a CT scanner, and the CT scanner goes down. So I'm like, crap! Am I really going to transfer this guy to another hospital because he's an old guy because he hit his head? The answer is yes. So I made arrangements, getting transferred. Okay, so the laceration, I saw the laceration. Okay? And all of a sudden, I don't feel so good. All of a sudden, the right people to 5. He was on Plavix. He died 4 hours later. The guy's walking, talking. Okay? So old people, okay, history is important. So old people, don't ask if they're on blood thinners, if they're old, worry about bleeding, do the scan if you need to, whether it's a head or a string, blah, blah, blah. So if they're hemophiliacs, okay, those people are hard to bleed, okay? So know people on blood thinners that may determine how you treat them, okay? Coumadin, you can reverse. Fresh frozen plasma, vitamin K. Kcentra is a new drug out, it's a new kind of reversal agent. There's these new prothrombin complex concentrates that are used to kind of treat some of these other medications. Plavix, 36-hour half-life. There's some people that get head bleed or bleed on Plavix or abdominal trauma or extremity trauma. Those people are going to bleed, okay? You have a 36-hour half-life. You're hoping, the bleeding slows down and don't have bad outcomes, okay? The newer 10A inhibitors, there's some drugs out there on the market, okay? Pradaxa has one out now. It's the only one. There's a couple down the pipe that are kind of reversal agents. So you need to know what these medications are on because you need to know how to treat them, okay? Yeah, they have a big fraction on Plavix or on tumor warfarin. You got to think about how you can reverse things that you can do to be thinking to maybe prevent compartment syndrome, okay? Also, edema. People, these extreme guys that are doing these triathlons and extreme workouts are sometimes getting into rhabdo, okay? From working out and stuff, going into having muscle wasting and going into renal failure. So they have muscle edema, crush injuries, okay? Trauma with or without fractures. Those are things you'd be thinking about. Okay, surgically graded, okay? Did they go and have a surgery and they have a bleeding vessel that's causing them to bleed in that area, okay? They can receive a tremendous amount of IV fluid infusions with other issues and injuries going on. That's supposed to be a Baker's, not a Baker's cyst. Okay. You know what a Baker's cyst is? Baker's cyst is a knee in the popliteal fossa, it can be big, size of a softball. Sometimes those can rupture and bleed. Okay, so you have a drug addict that comes in, okay, they're overdosed, they're unresponsive. What's an easy way to get IV access to these people? They have no veins.
No.
IO. Okay, IOs are easy. They take several seconds. So sometimes you can get intercompartmental, if you're not placing the IO right, you can get intercompartmental fluid infusion, okay? Capillary leak syndrome, intra-arterial injections, sclerosing agents can cause problems. Post-ischemic reperfusion issues can cause compartment syndrome. So clinically, how do we evaluate these people? Pain out proportion to the exam, okay, like we just talked about. Hyperesthesias, okay, they feel it burning or tingling, sometimes numbness. Okay, again, knowing mechanism, kind of what happened with a crush injury, okay. So something that somebody laying on their arm for a long time or leg for a long time. Physical exam, what do you expect in a compartment syndrome exam? What's the extremity gonna feel like?
Wood.
Wood, hard, tense, okay? So sometimes it's a lot easier to assess the tenseness of a leg or a forearm. Sometimes a little difficult to a finger, okay? There's so much bone, okay, in a finger. The tenseness, okay? So, you know, you see the 6 Ps, you say the 5 Ps, take your 7 Ps, you get it there, okay? Pain is huge, okay? But pulselessness is the last thing to go, okay? So you need to document, go through your Ps and document your exam. Pain is not our portable exam. There's no paleness of the skin. There's no numbness or tingling. Great pulses, got full range of motion, okay, normal temperature. So those are good positives, pertinent, and negatives, okay, in your examination, okay? Follow-up exams or study, okay, are real important, okay? Lots of times these patients that you're concerned about neurovascular injuries, you order Q1 hour neuro checks if you're admitting this patient or taking care of them, okay? Are real important. That lady, the lady from that other night that had the distal femur study about, the fact that she was, almost 12 hours out, she had bounding pulses, had a normal neural exam, the orthopedic surgeon said, she's kind of gone past the window. I'm okay with not doing any neurovascular studies, because we'll do pre-urinary neuro checks and make sure she had bounding pulses, good temperature, she had no neurological deficit, no paresthesia, she had normal exams. He was okay because she was so delayed in that with the normal exam that he was okay with waiting and not doing any vascular studies. One of the things that happens, lots of times you get the peritoneal, you start getting swelling in the lateral compartments, is you'll get, one of the first things you'll get as far as some paresthesias, you'll get a little bit of numbness in the first web space from the peritoneal nerve that happens. And kind of roots, we talked about it, sometimes compartment syndrome can be delayed, and patients have multiple injuries or altered level of consciousness, It's always nice when we can get a good history from the patient, or you have a numbness, you have a tingling, okay? Patients who are intubated or have altered mental status or other issues, or, have belly trauma, other issues, sometimes it's hard to determine what's going on. And so, sometimes it's like evaluating a child, they can't talk, okay? It's like evaluating a pet. They can't talk to you, they can't tell you anything, you're going off of your clinical judgment, your physical exam, and some objective studies, okay? So sometimes, having the ability to get your history from your patients or family members or paramedics has really helped guide your direction when you're going towards your injuries, okay? Clinical evaluation, high index suspicion, again, main cornerstone. If you suspect compartment syndrome, clinical exams equivocal or inadequate compartmental pressure should be measured. Many surgeons, the standard is 30. If you have a compartmental pressure of 30 or higher, that's essentially indicative of compartment syndrome. Okay? Pressure in all compartments should be measured. Compartment pressure should be taken as close to the fracture site as possible. That's where the compartment pressures are going to be highest in the area of the fracture. So Stryker needle. Okay? So if you're ever somewhere and you're in some place and you have somebody worried about getting compartment pressure, you need to know if you have a Stryker needle. Okay? That's what this is to measure compartment pressure. It's kind of cool, actually. So what you have is kind of a needle. You're putting this piece together. It's got an 18-gauge needle with a side port that you put together. Then you slide the needle, that port on the end of the syringe, and has 3 cc's of saline in it. Okay. The next thing you'll do is place it in the box, and you go ahead and bleed, push the air out. Okay. And then go ahead and assemble. And you go ahead and get it flush, and you get it zeroed, and then go ahead and inject it. It's pretty cool. One of our orthopedic surgeons, he does a lot of people. Sometimes he'll have these people have some of these runners have this chronic pain in their calves that they can't really sort out. He's wanting to rule out compartment syndrome, and you can actually do like an art monitor, an art line. You can go to the ICU on the monitors and actually use an art line and a needle and measure pressure. So there's kind of ways to, if you don't have a Stryker, there's other ways to do it. So differential diagnosis for acute compartment syndrome, cellulitis. Okay. Sometimes it's very difficult. Cellulitis, the skin can be really red, it can be hard, it can be indurated, it can be firm. Okay? A lot of times people come in with abscesses on their legs. The skin is hard and firm. Is the skin hard because the muscle tissue is edematous because of infection? Or is it because of an abscess? So sometimes you can get really hard skin with cellulitis. Okay? Swelling and pain in the leg. Okay? DVT. Okay? What is one of the exams that you do for DVT? Homenstein is what? What is it?
Pain. Yeah.
Pain with what? What range of motion? Flexion of the foot, okay? So, you know, when you're documenting for a DVT exam, okay, they have a palpable cord, they have pain, okay, on examination, they have pain, passive obstruction, they have pain, the swelling, the redness, they have more. Okay, things you want to document on all these kind of stuff. They have gas gangrene. How can you, what's a kind of a simple way, sometimes you can see gas gangrene on an x-ray, okay? Sometimes you can see on a soft tissue x-ray of the knee, someone's got pain on the portion of their leg, and you get an x-ray. Okay, sometimes you can see gas in the soft tissue on a plain film. They have necrotizing fasciitis. They have a peripheral vascular injury. They have rhabdo. We had this girl we took care of, oh gosh, probably 20 times. She was a drug addict, and she shot up in her femoral artery, and she got necrotizing fasciitis in her thigh. So we took her to OR like 8 or 9 times to debride all these muscles. The muscle tissue was dying. And then she'd come back with MRSA cellulitis. And the only way she'd get access to the port, so we had to put a central line in there to get IV access to get ready antibiotics. And one day she was getting ready to be discharged, and we were getting killed on the trauma bay. And she left AMA with her central line to go do drugs. Awful. But you'd be in the elevator. She's no couth, obviously. And she had no underwear on. You'd be in the elevator with 15 people. She'd say, hey, look, Brad, look at my thigh, it looks great. And no underwear on. Like, not good. Here you go. Okay. Management. Compartment pressure can be measured using different devices. The striker needle is kind of is that little equipment piece that was showing how to measure it. You can use other catheters to do it. Management. Okay. How do we fix people who are worried about compartment syndrome? Okay. So if they have a splint on, do not believe all the time people come in, oh, my splint's too tight, my hand's going numb. Okay. You cut their cast off, you take their splint off, okay? All kinds of things, those are simple things you can do. Elevate your arm, those are simple things you can do to kind of reevaluate. So, or at least those type of things. And your doctor buddy mine got sued for a dressing that he never saw a patient. Got put on, one of the techs put on a dressing, didn't examine them, and after the splint was placed on, it was too tight, they ended up getting compartment syndrome, and ended up getting sued. So if you put a splint on somebody, if a patient orders a splint, go examine them after it's put on, document, you examine the neurovascular. Talk to the patients, talk to the family, talk about assessing per capita refill pulses and sometimes symptoms to look for to come back, okay? So obviously removal of external causes if you can, okay? Web roll, there's 2 types of soft roll you put on splints. One is soft roll, which is real soft and cushy. The other is web roll. Web roll is kind of compressed foam padding. It's really doesn't give. It's really kind of tight. I don't like using web roll. Sometimes some will get ordered by accident instead of the soft roll. So instead of the cushy padded stuff, web roll is really it doesn't have any give. It's not really much padding, so it's bad stuff. Don't use web roll. You know, how can you do it? You can correct their coags. Obviously, if people have hemophilia, they're on blood clotting, disorders, or they have blood thinners. Those are things you can do. Elevate the limb. Treat hypotension. Okay. With hypertension and shock, but things are getting, if you have a fracture, an internal bleeding, and you're bleeding or hemorrhaging, you're not perfusing very well. So you already have an area of damage, so not perfusing an ischemic tissue is important. So you want to go ahead and treat them with fluids and blood if needed. Hyperbaric oxygen is kind of experimental. I don't know if it really works or not. So we talked about these external things. If things aren't better after 30 to 60 minutes after you remove the splint, remove the cast, or done some therapy, then you may need a fasciotomy. This is kind of a little dichotomy, a little key. If you suspect compartment syndrome and have positive signs, do a fasciotomy. If the patient's not alert, unreliable, victim, inconclusive clinical findings, you can check their pressures. If it's greater than 30, fasciotomies left, and kind of observe and kind of follow those. So management, definitive treatment is a fasciotomy. You know what a fasciotomy is? Okay? You want to leave all the pressure. Okay? Sometimes in burn patients, you'll get fasciotomies, okay? Sometimes not in the typical areas we talk about, extremities, okay? You get people who get burns to the chest. Sometimes you do a bovie, do fasciotomies on their chest. Sometimes you do fasciotomies on their neck, okay? So burn patients with circumferential injuries will need fasciotomies in addition to patients with orthopedic injuries. So after decompression, okay, so what they do, they take people to the operating room and they'll open them up, okay? The most common is the double. So you get on the ledge, you do it on both sides of the compartment, okay? And so what happens, is really kind of based on what they see. If you already have ischemic tissue and the muscle isn't looking great, it's looking kind of dark and dusky, if it's already rotten or dead, they'll do some debridement. Lots of times they'll go back to the OR a day or two and take another look to see, even though you've released the carpet pressure, see if the muscle is still viable. So if it's viable in 2-3 days, sometimes they'll go ahead and close it back up. Now, if they've had extensive orthopedic injuries and extensive fractures and just a buttload of swelling, sometimes it's delayed for a week to 10 days before we'll take them back and close the fasciotic sites. Then we talked about skeletal fixation. They need to do external fixators or plates or an IFL. They can all do it at the same time. There's kind of 3 approaches. The fibulectomy is not really approved. Single incision is really not really useful. It's not done as frequently. Most of the time the double incision is done. There's your compartments. Got my handy dandy pointer. So really, the laser won't show up on these plasmas, Dan? Is that what you said? That's crazy. That's crazy. So prognosis is really kind of depending on how quick. So these people, how quick you can get a fascia to be done, okay, and to preserve their neurovascular status. Okay? Myelonecrosis happens when ischemic assault, 8 hours or more duration. Say if you're 6 hours in a 6-hour window, lots of times you'll get return blood flow, everything will be okay. Complications, you get contractures, Voltman contractures, okay? You can get neurovascular injuries, infection, amputation, rhabdo, renal failure, and death, okay? And the patient presents, if you miss compartment syndrome, these people show up all their muscle tissues do it, okay, which is awful. So prophylactic fasciotomy for forearm or leg has been performed. If arterial ischemia has been present for 4 to 6 hours, should be considered whenever an open fibular fracture is debrided or tibial osteotomy is performed and fractures. Okay. The chronic compartment syndrome we kind of talked about earlier. A lot of these people with exercise-induced pain, chronically in the limb. What they'll do sometimes they'll measure. They can go ahead and measure the compartments, and if it's 30 millimeters after 1 minute of exercise and 20 after 5 minutes of exercise, they kind of plug it as compartment syndrome. Sometimes they can get a little procedure to kind of open up a little bit, or sometimes changes on their exercise regimen. Some other causes of chronic stuff is intermittent claudication, stress fractures in the tibia, periostitis, tendonitis, posterior tibial tendon entrapment, superficial nerve can cause symptoms. So workups, for some of these chronic things, you can get x-rays, bone scans, if you have periostesis, will kind of help with that. Tenniel's test may be positive for perineal nerve issue, entrapment. Nerve conduction studies sometimes can be helpful if you're working with these chronic people. MRIs sometimes as well. So these non-operative measures talked about is sometimes NSAIDs, nerve stimulation, massage, muscle relaxants, ultrasound, reduction of activities, or even a fasciotomy. But most of the time these people are just extreme people, so you kind of back off their exercise regimen. So I want to read you guys a email. I'll forward it to Dan. I forwarded it to Dan last year. One of the things in medicine is you can do everything right and still get sued. Okay? So compartment syndrome. Email if I can find it here. Reasonable practice, the ruling. A plaintiff alleged that PA was negligent for failing to consult his supervising physician or an orthopedist before ruling out such a serious diagnosis. The plaintiff alleged that after reviewing and signing off on the PA's note, the attending physician should have recognized the patient had multiple symptoms consistent with compartment syndrome and should have called the patient back for further evaluation. The defense argued that the patient's symptoms were nonspecific in nature and that non-traumatic compartment syndrome in an otherwise healthy patient is rare, and that with the patient's history and recent physical activity, initial diagnosis of a muscle strain was reasonable. In addition, the defense alleged that the injuries the patient sustained were caused by the refusal to return to the emergency department when his symptoms worsened through the night. The jury believed both the defense and the plaintiff's arguments. Their total verdict was $7 million, with 20% attributed to the actions of the physician assistant, 40% attributed to the actions of the supervising physician. The relatively higher award against the attending physician resulted from medical testimony, hospital protocols, and statutory language demonstrating that when a PA treats a patient the supervising attending physician is still ultimately responsible for the patient's care. The jury also reduced the plaintiff's award by 40% for the patient's comparative negligence in refusing to return to the emergency department as soon as when his pain worsened. Every time you discharge a patient or talk to a patient, document that you talk to them about, hey, if your signs or symptoms get worse, come back, okay? And sometimes, you know, even working in emergency medicine, we don't always find the cause for people's problems. Our job is to rule out life-threatening issues. Sometimes you have these patients that come back, you know, whether it's a belly pain, okay, and they have, you know, they don't have a very impressive exam. You get a CT scan. Sometimes it can be early appendicitis, okay? Sometimes they don't see the appendix on the CT scan. Encouraging these people to return in 12 hours for a repeat visit is always a good thing, okay? People that you're concerned about, that you're worried about, have them come back the next day. Have them come back in 12 hours, okay? Give them strict abdominal pain precautions, neurovascular problems. These people you're worried about, I don't think they have compartment syndrome, there's a little more swelling than I think should be there. Have them come back, okay? Have them come back for a repeat exam, okay? And it kind of goes on to say, acute non-traumatic compartment syndrome is considered a rare diagnosis. Compartment syndrome is often but not always a result of traumatic injury. Several sources note that compartment syndrome occurs in between 1 and 10% of lower leg fractures. Other causes of compartment syndrome include external compressive forces, postoperative complications, burns, vasculitis, DVT, seizures, infections. Non-traumatic exertional compartment syndrome is largely relegated to case reports within the medical literature. A diagnosis of compartment syndrome brings with the suspicions of the P's, like we talked about. However, be aware that some of these symptoms are late manifestations of compartment syndrome. By the time the patient develops pulselessness, paralysis, or pallor, it is likely that significant damage to the underlying tissues already occurred. Confirmatory testing involves intraarterial compartment pressuring by a Stryker needle. Talk about greater 30 millimeters is positive. In this case, the jury had to decide two issues: misdiagnosis and supervision. The patient presenting complaints included pain and swelling of the lower leg. While there was no bony point tenderness or erythema, there was also no documentation of the patient's distal circulatory sensory motor neurological exams. So had this PA documented his neuro exam, he probably would have won the suit. He just said there was no compartment syndrome and didn't really document a neurological or neurovascular exam. Okay? Although the physician's assistant's notes stated the patient had no evidence of compartment syndrome, both pain and swelling are evidence of compartment syndrome. Although these are non-specific findings, the notation that there was no evidence of compartment syndrome when evidence of compartment syndrome did exist made it more difficult to defend the misdiagnosis. Based on the examination documented, diagnosis of muscle strain or shin splints seems likely it was a reasonable diagnosis. However, if the sensory motor and circulatory exams were a normal exam, notation of the normal exam and better documentation of the description of the swollen area in the patient's leg may make it easier to allege the patient's symptoms didn't warrant a fasciotomy. Okay? So, you know, doctors kind of talking about documentation. You know, you can do everything, you know, obviously there were some mistakes here, but you know, that's the crazy thing was, you know, we always tell people to come back and return. I mean, it ended up being a $3 million settlement instead of $7 million because the patient didn't return and the symptoms worsened. But, you know, knock on wood, you know, I've been fortunate enough to not be sued. Dan, what is it? Once every 10 years, isn't that kind of the average?
7.
7. 1 every 7 years. Okay. I've been called to testify in a bunch of cases, and you know, there was a trauma patient one time that was kind of the 45-year-old guy that lives at home with mom kind of guy. Motorcycle accident, had a brain injury, had pelvic fixators. He's very impulsive because of his brain injury. Lots of these impulsive people, you know, get up and fall. The mom kept untying his restraints, and he fell. It's documented by myself, it's documented by everybody, mom kept untying restraints. And so I get called an attorney, it's like, you know, it's been a couple of years, I read the chart, it's like, did you guys not read the chart? You know, it's well documented, you know, that the mom kept untying the restraints and kept running, you know, so anyway, they dropped the case. But, you know, documentation is important, you know, and that's the thing that stinks about the electronic medical record these days is the electronic medical record is here, you know, working the ED, lots of times you used to have, you know, little T-sheets or dictations. It would take you 5 minutes to see a patient. Now it takes you about 15 because you have to document so much. You know, none of the electronic medical records are great. Some are better than others, but they really slow you down. But it's real important to take the extra time to document the extra stuff. Because if you didn't, even though you had the conversation, if you didn't write it down, it's your word against theirs when you get done. So, any questions today? Thank you all for your time. I know it's kind of a lot of information. I appreciate you all and have a great day.